nurse practitioners, psychiatric nurse practitioners, behavioral health clinicians, and pharmacy who sit on the faculty. And then the next year, we launched the substance use disorder ECHO as well with a grant, which I'm going to talk to you a little bit about. And so we've been doing this, but this is monthly, and same thing, multidisciplinary. It started out really trying to scale up buprenorphine treatment specifically for opioid use disorder, and then it quickly sort of morphed into, you can't really do opioid use disorder without really doing substance use disorders overall. So this is the operational data. So we can say, yes, we're successful in implementing this, that it's still going on 10, 11, 12 years later. And you can see here that we have put on hundreds upon hundreds of sessions. We have trained over 1,000 providers who've come through our ECHOs. We have engaged over 250 or so clinics throughout the US in over 25 to 30 states. And we have actually also given thousands upon thousands of CME hours. So that's the other thing that we did as well to track participant buy-in, is if you come and join for an hour and see us, you get the CME for an hour. So that way it takes care of a lot about the continuing medical education. And so this would say success, right? Like we've been able to keep doing this. But again, in the back of my mind, I'm constantly thinking, what about clinically? Is it changing the impact of clinical care? And so we still need to sort of continue to connect the dots on that front, which is where we need all of you to start thinking about implementation, sort of, science being sort of along with the clinical sort of outcomes that we want to sort of look at. But because we've done so much CME, every time you fill out a CME form, they have to sort of answer a lot of the the evaluations in order to get the CME. So based on these evaluations, we've got hundreds upon hundreds of evaluations. And you can see here, for both ECHOs, very high rates of satisfaction for the faculty, for learning and gaining new knowledge, and it being relative to good practice. And so, and you've got, we've got all these comments all the time. And so, okay, has this been successful from a provider and participant satisfaction? Yes, it looks like very satisfied. People really enjoy coming to the ECHOs, and hopefully they're learning a lot. In the back of my mind, always, all right, so that's true, but is it changing clinical practice? I hope so, because I've been doing this for 10, 11 years. I hope we're changing practice, but we really need to continue to sort of connect those dots. And then the other question I constantly hear my senior leadership say, how long does somebody need to stay in ECHO? Right? Is a year enough for them to sustain their knowledge? Is it 3 years? Is it 6 months? So again, we need to sort of find those things out. Weekly, is it enough? Is it monthly? And I think sometimes it depends upon the discipline. I think substance use, what we're doing monthly is enough. Doing all that we're doing with HIV and Hep C, I think really weekly has been quite successful. And so we got to also answer those questions. So that's all I'm talking about. So what's the next level of data, right? Clinical effectiveness and implementation. And so thinking about that, you got to think about, all right, participant, so what can we look at? So did we change people's knowledge and confidence in what we're training? So let's say in this case, HIV care. Did we change their approaches and attitudes, right? So especially this is true when it comes to transgender care, right? Or it comes to treating people who inject drugs, or MSM, right? There's a lot of attitudes that are really stigmatizing and discriminating. So did we move the needle on that? Did it really change clinical practice? And did it affect and improve patient care and treatment? So remember what everybody said when you're thinking about doing something like this, you've got to start out, in addition to the clinical implementation and what you want to do, bring in research and evaluation from the start. Absolutely, I cannot say that enough. So in 2013, when we got the federal grant, it wasn't a research grant, to really scale up sort of buprenorphine treatment for opioid use disorder. I thought it was very clever and say, okay, although it's not a research grant, let me do a survey of our participants. And I thought, oh, this is great. And then after we sort of did this in 6 months, I thought, okay, wait a minute. We've got the survey, but how is it linking really to how often were these people really engaged in it? So do we have that data? And then is it changing the number of patients they're prescribing buprenorphine to? Because that's what we want to move the needle to, right? We want to improve access. So suffice it to say, we got really good, so we had the survey data. we did have all the data of the number of sessions that they attended, the number of cases that people presented when they joined. And then retrospectively we said, can we go back and look at our electronic health records and really look at how many patients people were starting buprenorphine? The problem here is that the people who answered the surveys, we couldn't really link directly to the participation data or to their prescribing. So we had all this little data, but we really could not connect the dots. But I think it really told a good story. So we had 34 participants, so 21 medical providers and 13 behavioral health providers, of whom only 23, so 13 medical providers and 10 behavioral health providers, who answered both the baseline and the 6-month follow-up surveys. And these surveys, and I'm not going to go too much detail here, I'm just looking at the time, but these surveys really did well. So we did 3 parts to the surveys. The first part was really, what is your self-efficacy when it comes to clinical skills and your ability? And you can see here that 14 out of the 16 sort of measures really were moved significantly for medical providers, and it did the same for behavioral health providers. When we looked at the team-based care, right, because we really sort of spoke to team-based care, it did sort of move the needle a little bit, because we constantly talked about that, for the medical providers in terms of, valuing the nursing as well as the behavioral health providers and managing the patients. And then for the attitudes, it really moved the needle for the medical providers, because we found that although they found that these patients were more disruptive to the clinic, it was still, they said it was appropriate to treat buprenorphine in primary care, and it really improved the professional satisfaction. And with behavioral health, it showed the improvement in their self-efficacy. It did, because behavioral health really don't have nursing and medical assistants, but they do engage with medical providers. So we did improve that piece of the team-based care. Didn't really move the needle on attitudes. But I circled this here because they already had fairly high sort of rates of where we wanted them to be when it came to attitudes. So maybe that was the reason why it didn't move significantly. Separate from that, this is the prescribing data, which I thought was really good. So during that same period of time of the surveys, we really looked at 23 of the prescribers who could prescribe buprenorphine at the time. And we really divided them both in inexperienced providers and those who were already experienced providers. And we really didn't find a difference there. Then we broke that up and said, all right, of these, all the inexperienced providers, who were 12, actually attended ECHO, and 6 of the 11 of the experienced attended ECHO, the other 5 opted not to. And so when we looked at that, the total number of patients who were prescribed during this period of time was almost 900 patients. And on average, each provider had around 40 patients that they were prescribing to. But of that, almost half of them were newly inducted patients. So this is great. It really sort of, newly inducted sort of first prescriptions happened in this period of time. And the average number that were being prescribed by each provider was around 20, which was what was my anecdotal experience of how many patients most of the primary care providers in the full panel could actually handle. And so we couldn't really, like I said, connect the dots of saying, oh, the people who really answered well in the surveys really sort of scaled up the treatments. But in terms of what we saw, I can't help but believe that ECHO really empowered the inexperienced patients to really start up the same number of patients that the experienced was during that period of time in terms of inducting these number of patients. And the experienced providers who attended ECHO almost by a good majority had more patients on their panel than the experienced providers who were not attending ECHO. So I hope that there was some movement from that ECHO. However, like I said, we need more and better research. And of course, you heard about Dr. Altice, who brilliantly sort of came up with this particular study in Ukraine, and really looking at some of these questions, right? So it's a type 2 hybrid cluster randomized trial, really looking at integrating opioid treatment, HIV/HIV services in primary care. So they're comparing specialty care, which is the treatment as usual, to primary care, and the primary care providers, the intervention was providing ECHO to support them. And then the primary care providers were broken up into people who were getting a financial incentive, a pay for performance, versus not. And so then using this teleeducation intervention, we were able to, first of all, collect survey data on the participants, really looking at the implementation piece. How was ECHO? Was it acceptable? Was it appropriate? Was it feasible? how was the faculty in terms of expertise and presence. They did the operational sort of data, we collected that, in terms of the number of echo sessions that were attended, the length of time people were in it, number of cases that were presented. Then they looked at clinical outcome data as well, which looked at quality health indicators, looking at primary care and primary and specialty care services and screenings. And now we're in the preliminary study of really looking at the process of how well was the echo implemented, right? And then determining that fidelity sort of criteria that we need in terms of how we're going to sort of scale this up in other places in terms of the implementation piece. But also, is there going to be any association of what's the right sort of balance of echo participation with improvement in quality health indicator outcomes? So very exciting stuff to come. All right, in the last 10 minutes or so, I'm going to talk about some of these other web-based interventions. I'm going to try to go through a little bit fast. So as I told you, these were led by Valerie Earnshaw, fearless leader, where she was going to launch the ECHO to support Malaysian primary care providers in starting HIV prevention sort of care, really looking at the key groups, MSM, transgender women, people with HIV, people who inject drugs, and female sex workers. And so the idea was we were going to implement this ECHO, but she really wanted to do the project was looking at doing focus groups with participants, providers, to see how best to implement this ECHO, right? So but because of COVID, shifted completely to telehealth web-based focus groups. So here as an intervention using telehealth to sort of help us implement another telehealth intervention. And if you think about this in terms of shifting this, the strategy really minimized barriers to in-person focus groups. So it was less time for the participants that they needed to participate in. It was more confidentiality there, so people used screen names instead of real names, and we were able to gather more people from diverse geography background from all over Malaysia. And this was web-based, hosted by Focus Group It, and 4 focus groups were conducted over 3 weeks, one for each of the key groups there. And they recruited 34 total participants, so 7 to 10 participants in each group. And each focus group lasted 3 days. The first 2 days were on perceptions and treatment of the patient group that they were being asked about, like MSM, people who inject drugs. And the third day was on Project ECHO. And they gave them a little bit of explanation. What Project ECHO was, they made them see a video on Project ECHO that was 1.5 minutes long. And each day on the website, they would pose brief questions, posted in the morning and evening as a discussion prompt. Participants would receive an email notification and a reminder saying, hey, the question's up, would you please sort of answer? And then only after answering a question were the participants able to see the other responses. And there was compensation that was given. And this truly was very, very successful. There you can see the demographic data, but this then we gleaned facilitators and barriers to Project ECHO that in many ways was fairly sort of consistent to what we see for facilitators and barriers in other projects outside of Malaysia as well. So it was really very well done from that perspective. This is another one where it was the same project, and remember what I said, patient voices are very important in terms of input. So this we were going to be using photo voice to really engage people from each of these key groups and really hear about their experiences with medical providers, with the healthcare system, and what made them happy, what made them sad, to really humanize them for our target audience in the ECHOs, which is the primary care providers. And again, this was supposed to be in-person photo voice, and it had to shift because of COVID to all web-based, and was incredibly successful. We got 34 participants, one from each of the 5 categories of key groups. All the photo voice guidance, the training, the submissions, how to take the pictures, were all done asynchronously and online, and there was some interaction with the researcher only by phone. Now the benefits of this, especially in this very vulnerable populations, was that it overcame geographic constraints, but it also definitely relieved the confidentiality and safety concerns that if they had to come in person to do it. So really, it worked very well our participants. We had to design a website for it. And then the website was compliant with confidentiality standards, names weren't used, faces and surroundings were not allowed, dummy emails were created, and consents were obtained, and they had instructional videos that were created. And we had 100% completion rates. And you can see here 2 pictures here that really were very touching, and you can go to the published paper, there's more pictures of this on this. But really incredible touch points. The bottom one was a dot, which was a moon in this, and it really is about how this particular doctor saw him as actually being seen in his sort of life of chaos in many ways, and that how he was an MSM with HIV. And so really very touching. The other one, the top one, is a female sex worker. And it really evokes what many of us love the beach, love the wind, feel happiest there. She basically said, I'm happiest when I'm at the beach, and it might make it a point to be able to go to the beach once a month to reinvigorate, right? We can all understand and connect with that feeling and really humanize as somebody who might otherwise be stigmatized because of the sex work she engages in. And lastly, in the last 2 or 3 minutes, I'm going to just shift a little bit and talk about the multifaceted strategies that could include telehealth. I know Dr. Madden talked about Niatech. This is another multifaceted strategy. And I'm going to talk briefly about the learning collaborative that I'm involved in, and I have been for the last 4 years, in the emerging issue of HIV prevention, trying to scale up PrEP in federally qualified health centers across the nation. And so this is through what we call NTAP, which is the National Training and Technical Assistance Partnership. mHealth Center has one to really develop the clinical workforce. You can see here that we have team-based care, training the next generation, and so on and so forth. And so I lead the HIV prevention piece. So this is really a learning collaborative where we do 6 90-minute monthly learning sessions. They're sort of like a webinar, but more interactive. But then we also do bi-weekly 60-minute coaching calls. We basically enroll 10 to 12 health centers who apply for this, and we identify who their PrEP program leads are. And so then we open up these learning sessions to all of their health center people who can join, so it's a much bigger group that comes into those learning sessions. But the bi-weekly coaching calls really are virtual and bring in the leads for all these programs together every couple of weeks. And then we also use another web-based learning platform called Moodle, where everybody uses this, both participants and organizers, to be able to communicate and network. It also acts as a repository of resources. People can upload the deliverables that they had to do as part of the learning collaborative, and it's a great way to disseminate information among them. And you can see here some topics of the learning session overview, and they're really sort of intense, but really very well received. As you can see here, we get them to sort of rate them, and they're always very highly rated, thank goodness. A lot of effort goes into this, and it always feels good that we get good ratings. But we also encourage them to give us good feedback, right? There's nothing worse than doing something that you feel is not really connecting with your audience. And so we really honestly want their honest feedback to do this. But even the coaching calls, sometimes I feel like, oh my God, are we just sitting here all together? But it's a great place, very well received by the leads. They share resources, right? They tell each other about how they did their program, how they talked to their senior leadership, new sort of thoughts about how to do outreach. And these are people across the country, north, south, east, west, and this is a great way to be able to share and learn from each other. And that's what sort of has happened there. And then at the end, we really look at what were they able to implement in the 6 months that we did this, and what were their barriers to implementation. And it's really fascinating that you can see here that we want them to scale up PrEP, but a lot of the times the things that they were most interested in doing and were able to do was really work up the screenings, right? They're saying we weren't collecting sexual orientation and gender identity information. We're not taking sexual risk assessments in a way that is right, so not judgmental. We weren't able to sort of convince our providers to do X, Y, or Z, and so we gave them the tools for the learning collaborative. We share our policies. We share our electronic health record sort of prompts, I do all the sort of sessions on how to take a good sexual history, how to collect all of this, what the workflows are, about PrEP and so on and so forth, and it seems to sort of really be helpful for them to start to establish these programs and hopefully start to move their champions along to starting prescribing PrEP. And so in summary, I'm a minute and a half over, so I can't believe I actually did this. I do talk fast, so hopefully I've kept you awake. I didn't see anybody fall asleep, so maybe I'm successful in that, but really use telehealth, right? COVID taught us that we can do a lot in telehealth, and there's a lot more openness to actually using telehealth across the board. But it also is very cost effective. I didn't talk about the skills sharing project that we do with our Ministry of Health in the US, sort of with PEPFAR countries in Uganda and Jamaica. But as we were talked about earlier, PEPFAR and other global funds are taking away their funding, and so people really want to find ways to sustain a lot of the support that we're doing. So the skills sharing project is only 2 sort of site visits in country, 2 weeks apart, and the rest is really supporting them through virtual sort of echoes, if you will, as well as through WhatsApp. And it has really been very successful in Uganda. That's moving it forward elsewhere, and it is extremely cost effective. And so again, thinking about ways to do this. So use telehealth, either as discrete or part of multifaceted strategies. Choose the telehealth strategy that will work best in the context you're working in, whether it's echo or coaching calls or telemedicine even, right? Plan from the start, as I said, to study telehealth strategies and interventions to better inform how best to use it and implement. And please, we've got to disseminate what we're doing so that we all learn from each other and continue to scale this up in a way that benefits, at the end of it, our communities and our patients that we really care about. So thank you so much.